A very good evening to everyone, and welcome to No Thrombosis program. And as you all know, that No Thrombosis program is one of the India's most engaging scientific platform in any pharma companies. And this has only happened because all the faculties, all the faculties, contributed in this program, and all the delegates, those who are consistently they're participating in this program, and they know they will get some insights every time whenever they come to the programs. They'll get some insights and some useful information from this program. So thank you so much to all the delegates and faculties. And today's our course director is none other than Dr. M.S. Maksud, the well-known international cardiologist in India. And second is that Dr. Girish, or moderator, the first moderator is Dr. Girish V. Nosundani sir. Dr. Girish Nosundani sir is the director cath lab in senior interventional cardiologist from Apollo Hospital. Dr. Nosundani sir has performed over 4,000 plus angiograms and through femoral and radial and ulnar approach, and about 1,600 angioplasties, both coronary and peripheral. So he is the first cardiologist to implant the absorbed stent in private healthcare sector in the state of Karnataka, as well as he is the first cardiologist to implant MRI compatibly AICD system in the state of Karnataka, and first cardiologist to implant capillary coronary stent in the state of Karnataka. And also he has participated in many pathbreaking clinical trials. So from behalf of MCure, I welcome Dr. Girish Nosundani sir. Welcome, sir.
Good evening.
And our next moderator is Dr. D. Prabhakar sir. Dr. D. Prabhakar sir is treasurer of CSI 2022 in Chennai. And Dr. Prabhakar sir is a senior consultant and interventional cardiologist and associated with Apollo First Med Hospital and Ashwin Clinic, Chennai. Prabhakar sir is assistant professor of cardiology in Madras Medical College during the time of Chennai in 1998 to 2002. He has participated in many international and national conferences as faculty and published many articles in reputed national and international journals, also published in many books. So from behalf of MCure, I welcome to Dr. Prabhakar sir. Welcome, sir.
Hello.
And today's first speaker is Dr. M. Pani Teja. Dr. M. Pani Teja is international cardiologist from KIMS, in Bolneli Hospital, Rajmundry. This hospital is the largest cardiac center in coastal Andhra. Dr. Pani Teja is visiting consultant to various hospitals in Rajmundry. He is a member of the PCSI and Cardiology Society of India. So welcome, Dr. Pani Teja sir, for this program. And our next speaker is Dr. Somen Prasad Behra. He is from Bhubaneswar. Dr. Somen Prasad Behra completed MD DM in cardiology. He is presently working as interventional cardiologist in Apollo Hospital, Bhubaneswar. So today's our agenda is to first we'll have a case discussion. First case discussion with Dr. M. Pani Teja and Dr. Somen Prasad Behra. And presently, Dr. Hiremat sir will be joining soon. And once he joins, he will also going to present one very unique case today. So I request Dr. Prabhakar sir and Dr. Girish sir, please take it forward here. Thank you, sir.
Good evening, Mr. Kesur, and I welcome Dr. Prabhakar, very learned man, to bring his wisdom to today's discussions, and young two colleagues of ours, and we're very proud because every cardiologist who comes on to this platform adds another dimension of thrombosis discussion, and we all get to see a case where we need to explore the probability of using the appropriate anti-thrombosis mechanism. And MCure has been, really invested heavily in the discussion of thrombosis. For an interventional cardiologist, or even a physician, or a neurologist, or an interventional radiologist, thrombosis is a very, very big concern, because the number one cause for death today is cardiovascular diseases. So the more we understand this, the better we would be at preventing and treating these problems. So I thank MCure for bringing all of us together. And with this, I request my co-moderator, Dr. Prabhakar Doraraj, to give his comments and start the program.
I think you are given an introduction. I think we will spend more time on discussion. I think who's going first, Dr. Teja or Dr. Behra?
I'm going to present my case, sir.
Dr. Teja. But I should also tell you that it's wonderful to share a stage, or whatever you call, share a screen with Dr. Nausundi and Dr. Hiremat. It's always very interesting, and interesting fights keep happening, and at the end of it we all learn a lot. That's the general motto, and it has served its purpose very well. Go ahead. Teja.
Yes, sir. Good evening, sir, everyone. Actually, before going to my case, I would like to thank Hemcure Pharma for providing me the opportunity, sir. Actually, my case is my only a small part is only thrombosis. It's actually an interventional case, sir. Sorry for that.
There is no interventional case where there is thrombosis not a concern, Dr. Teja. So it doesn't matter.
Actually, I have completed recently from Bangalore Jaydeva Hospital, sir. One of my senior colleagues, Dr. Pranit, was working with you.
So nice to know that, and wish you all the best in your career.
Thank you, sir. Yes. Coming to my case, sir, this was actually, the title was Bailout When All the Doors Are Closed. An idea that avoided the knife. Coming to clinical details of my case, this is the case about a 16-year-old gentleman. He's a thin-built gentleman who is having risk factors of diabetes and hypertension for many years, for almost about 10 years. And he had a recent inferior wall MI for which he has got primary PTCA to right coronary artery with 2 stents in some other centers. And after a few months, around some 4 months after the initial MI, he presented to us with significant exertional angina, effort angina, and shortness of breath, sir, for which we have advised a check coronary angiogram for that guy, for which the patient readily agreed, and we have done a coronary angiogram. And to our surprise, it has showed significant lesions in LAD and LCX, and a large aneurysm is seen in the proximal end of the RCA stent, but with distal TIMI3 flow. Now I am showing the videos of the right system, sir. In this, you can see a large aneurysm at the proximal end of the stent, but distal flow is there. So this was the initial angiograms of the right coronary system. We have not done any intervention to that aneurysm.
If you put that in an auto loop, it will keep playing.
Actually, I have put it, sir, but somehow the problem was there.
No issues. Go ahead.
Yes, sir. We have not addressed that aneurysm, and we have fixed the lesions in the LAD and LCX, sir. And we have shifted the patient to ICCU for observation. But patient has developed a complete heart block, cardiogenic shock, and when we have done a 2D echo, we have seen moderate pericardial effusion, sir. This is after 1 hour after the procedure. After fixing the left system, patient developed complete heart block, cardiogenic shock with pericardial effusion. Immediately, we have put a femoral temporary pacemaker, and we have drained about some 150 to 200 ml of pericardial fluid, which was blood. We have aspirated. Then we have taken the patient to cath lab for check angios. Check angio showed, to our surprise, check angio showed the left system, the LAD stent as well as the LCX stent was completely patent, but the right side, which we have not done any intervention, was occluded with thrombotic 100% occlusion. On my left screen was the shoot, sir, which is showing thrombotic occlusion, sir. The video on the right side is after carefully passing the PTCA wire, sir, which was feeler FC wire. We can see the giant aneurysm, sir, with so much of thrombus which has migrated downstream. This was literally unexpected, as we have not done any intervention on the right side. There we have anticipated that the aneurysm might be some pseudo aneurysm which has developed thrombosis. And the patient, after aspirating pericardial blood and putting TPI on patient, we have started inotropes. The patient's hemodynamic status improved a little bit. But then we have explained about the problem to the attenders, to the bystanders, and we have undergone and we have gone for covered stents. We have only one covered stent available on shelf, sir, which was about 2.8 into 16 mm graft master stent. We have only that size available and only one single stent available, sir. So we want to try our luck with that small size stent, and we have deployed it with appropriate post dilatation, sir. But the leak at the aneurysmal site continued even after putting the graft master. Patient still, I mean, we are able to still aspirate blood from pericardial sac. Patients is still continuing in the hypotension. Then we don't have any other covered stent available on shelf, sir. This is a tertiary center, and we know that we will not be able to procure any graft master stent readily from any other center. So we have thought about the option of bypass surgery, giving it, but patient is already in shock, poor hemodynamics, and attenders were also a little skeptical. So we want to try a new technique, which we have heard somewhere, sir. So we have on the spot, we have prepared one covered stent using two drug-eluting stents. We have taken two drug-eluting stents of size of 3 into 32 mm stents, the normal drug-eluting stents. These steps elaborate how we have prepared I will also show the videos of how we have prepared the covered stent using the two drug-eluting stents. This is just an outline. First, we have inflated the first stent outside, outside of the patient's body. Then we have cut the balloon. We have cut the balloon circumferentially at the both ends, so that we have taken out the stent as well as the sleeve from the first stent. And step 3 is the whole assembly. That means the balloon, sleeve, as well as the drug-eluting stent, we have loaded onto the new stent of similar size, appropriately placed, and we have crimpled the stent onto the second stent using our hand only. And as you can imagine, this there is a small balloon polymer layer between two stents, sir. So we thought this would solve our problem, seal the aneurysm, sir. And we have this image shows how we have prepared. So this is the marker is showing the first stent, sir, which we have slowly removed, and we have put on the second stent. Second stent, along with the balloon sleeve, we have crimpled it onto the second stent, and finally we have this is put in at the appropriate position of the aneurysm, sir. This video will elaborate how we have prepared the covered stent, sir. This is the first stent which we have inflated outside the patient's body, sir. The proximal end took some time to yield. We have gone to a little higher pressure, sir. We have cut the inflated balloon, the proximal end as well as the distal end of the balloon circumferentially. First, we have taken that balloon sleeve onto the second stent. This is the first inflated stent. We have placed it appropriately and we have crushed that sleeve as well as the stent onto the second drug-eluting stent. And we have placed it at the, as it is of big size, 3 into 32 mm stent. It has adequately covered the aneurysm, and this was the final shoot, sir, which shows that there is no active leaking at the aneurysm site, and it was completely sealed off with distal TIMI3 flow. And we have done adequate post dilatation, sir, with 3 mm as well as 3.5 mm post dilatation balloon. Then slowly, in few hours, patient's hemodynamic status stabilized, sir, and patient regained the CHB disappeared and converted into normal conduction. And we have put the patient on dual antiplatelet as well as the anticoagulant, sir. At 6 months now, patient, we have not done check angiogram, sir. Now patient is asymptomatic without any angina or shortness of breath, sir. We don't have imaging technique like IVAS or OCT readily available on shelf, sir. So we have not done any imaging in this case, sir. The take-home message with my case is that when conventional cover stents are not readily available, indigenous cover stents can be prepared easily by our technique of by using 2 drug-eluting stents. This technique can also be used when there is proximal, when the regular cover stents are not available. This technique can be used to prepare covered stents when there is proximal perforation or coronary artery rupture. With this case, I would like to end my presentation, sir. Thanks.
At the outset, let me really congratulate you, Dr. Teja. Fantastic job.
Thank you.
Saving life and thinking on the run is very, very important, because many would have thought, you know, I exhausted my single, what do you call, covered stent, and what do we do further? But at that point of time, while you're doing pericardiocentesis and autotransfusion, you had the presence of mind to have an alternative indigenous method of doing it. Fantastic. That's one way of doing it. My suggestion, if you have to go back, if you were to treat this patient again, you shouldn't, I wouldn't be doing it without imaging the right one before I venture upon the left side lesions. 2 simple reasons. Because when you look at an aneurysm of that size, as you truly realized later that it was probably a pseudoaneurysm which got worsened because of high anticoagulation that you used for the PCI. Till you did not anticoagulate to that level, probably, you know, the aneurysm was just growing and a small clot had prevented it from rupturing into the pericardium. That's what I can imagine, because you had not even touched that lesion and it thrombosed. And then you had pericardial effusion. So that means to say, my only suggestion, whenever we encounter a case like this, it's important that we refer to a place where that can be understood better. These are called stent failures. Wherever any stent fails, it's very important to understand the mechanism of failure. What is it? Was there a dissection and stenting was done? Probably while doing a pre-dilatation or post-dilatation, did they cause a tear or the rupture, small contained rupture of the right coronary artery, and which only went on becoming worse? Or is it just the drug-eluting mechanism that caused the weakness of the vessel? Or was there an infective endocarditis, some infection of that lesion which caused that? But what you did to bail out the case was fantastic. We have done couple other times just like this, when probably when you're doing in not our own hospitals but proctoring, or when you go outside and when you encounter like this. Two things you can do. One, need not use another stent. Just use a balloon and put a lot of contrast on the one stent surface, dip it in contrast, and take a sleeve of the same size balloon and put it on the stent and take it inside. Here you have taken a balloon which had a stent over it. That's okay. 2 layers of stent, it gives you a good, opposing stent.
In the end, patient had so many layers. Actually, the original stent was there. Then we have put a covered stent. Then we have put 2 stents with one almost 5-6 layers of wall was there.
Yeah, I am very sure that gradually something would happen inside of that. So it's worthwhile. Take the patient wherever you are comfortable and be part of the care of that patient, but do an imaging. Do an OCT, do an IVUS, and understand what's happening to the right coronary artery. That's my suggestion to you. That's one way of doing. Some people, what they do is they take out one of the veins, either from hand or leg, and they put contrast on a stent and then put that vein and take it inside and inflate it. So it's a very biological method. So congratulations.
Thank you, sir. Sir, I have one few doubts, sir.
Please.
Yeah, does this few studies I have seen, does the aggressive post dilatation leads to such type of complications, sir? I mean, your experience or something.
What I have realized is it's very important to appropriately size your balloon and stent. If you use the 1:1 diameter post dilatation NC balloon, that means if the vessel size is 3 millimeter, and if you use an NC balloon of 3 and go up to 20 atmosphere or 24 atmosphere, in a relatively healthy, non-calcified lesions, you don't expect much problem because the vessel can accommodate. But if there is a 90-95% stenosis, very fibrocalcific, and when you expand the stent, there is so much atheroma, it doesn't have space to become 1:1, isn't it? If it is 70% lesion and if it is fibrofatty lesion, then it will accommodate and cause no problem. So that is why always it is better to take 0.25 millimeter lesser diameter balloon and go aggressively at high pressures if it is not expanding in a fibrocalcific lesion, not directly with 1:1 size balloon. And what I've always realized is it is important to pre-treat the lesion. The job of the stent is only to scaffold the wall and deliver the drug. It is not the job of the stent to expand and get you the lumen. That you should have achieved by pre-dilatation. Oftentimes I've seen people are in a hurry just to use a 2 millimeter balloon to make a space for a stent and implant a stent, and then go at high pressures, try to expand an unexpanded stent. When it does not expand, I've also seen some youngsters upsizing the balloon size to get an expansion. That's very, very dangerous. If you put a 3 millimeter stent, and if the stent is not expanding, never use a 3.5 millimeter to expand it. It will only dog bone. It will injure the area next to the non-yielding area, and it makes it bigger than its normal size. So never oversize to expand a non-expanded lesion. Always use in quarter size smaller. Go at a much higher pressure.
I think Dr. Girish has given an excellent explanation on why you get a perforation. Now the calcification is a point that's very, very important. And these calcified lesions, when you pre-dilate, those are, and post-dilate aggressively, those are the ones that give way at some point. You have to be very careful with those calcified lesions. And preparation prior is absolutely important on a calcified lesion. Like what Sir said, if you use a 2 mm and then go ahead, what will happen is when you post-dilate, you will notice that it's never going to expand. And if you had done an imaging in that case, you will realize that you have not broken the calcium. But sometimes you're lucky. You use a high pressure and a slightly smaller balloon, like in a 3 millimeter, you use a 2.5 millimeter, and then do an imaging. You notice that the calcium is already broken. And if the calcium is fragmented, your stent deploys beautifully and you get a good result. If it doesn't break, now the point is, ultimate point is the imaging. Imaging helps a lot in a calcified lesion. So it will tell you when to go for something like a rota, or if you're going to using a IVL or whatever, your strategy, or if you want to use an OPN, you want to break the calcium, everything is possible in that. Now coming to your particular case, couple of things. One is, did you do an auto transfusion? Was there a drop in hemoglobin, pericardial effusion when you tapped it?
Yes, sir. We have done an auto transfusion.
Auto transfusion. So that is something that has to be understood. That best thing is to go ahead with an auto transfusion in these patients because it maintains the hemoglobin. So don't discard the pericardial fluid. Always make sure that you give it the auto transfusion. This does not clot inside the system because inside the pericardial fluid system, it doesn't clot. That is one. The second point is, in your case, when you used your covered stent, you can actually try to post dilate it to a higher size. Because anyhow, you have decided that that's not going to work. And you're going to put one more round of metal inside, because you can try, even if you break the stent or stent fractures, it doesn't really matter. Desperate measure, you can go ahead with something like that, dilate it. And the technique of using an indigenous stent, your technique is very simple with 2 stents, expensive, but the simpler technique is what Dr. Girish had said. Use a balloon on stent and then you can get it. But crimping that and getting it done, even there you can use it, but it's going to be a little difficult since you already have a stent. But in your case, your patient has got 4 layers of stents.
Yes, sir.
So it
Yes,
is
sir. 4 layers of
what
stents.
happen long term it's a very big question mark. But ultimately, I think what you did was perfect. Actually speaking, if you are sitting in a center in an emergency, your technique probably will be the easiest technique.
Yes, sir.
Dilate a stent, open it, and you must also understand in one step that you should say that you break the balloon and get the stent inside, the first balloon. Otherwise, you won't get the balloon inside.
Yes.
So you have to cut through the balloon and then get the crimping of this has to be a little careful. So you have to cut through the first balloon and then put it on that, and between the 2 layers, the balloon is open. The balloon should be all around that. And that is important. And if you go ahead and do it, I think your final result says it all. I think very well done, very well thought of, and end result speaks it. But I think, like Dr. Girish said, I think your follow-up is pretty important with 4 layers of stent inside. And why did you put an antithrombotic agent in this patient? Why did you anticoagulate this patient at discharge? Dr. Teja, you had anticoagulation plus dual antiplatelet. What is the reason for the anticoagulation?
No, sir. We are also of the opinion that because so much layers were there, so much this thing, and we have started. Only single, aspirin single dose, clopidogrel single dose, and we have put the low dose of acetrom, sir, 2 mg we have put to maintain the stent, covered stent.
I don't know, Dr. Girish, sir, I think I've also seen a couple of centers do this. For the first 15 days to 1 month, they use this 2 milligram acetrom business without any monitoring. And the next visit, they stop it. I've seen a lot of centers do it, but I don't think it's justified. And in your case, if your patient had been there, you can always call for an imaging. Your imaging is available. These guys get it to you for free. You just have to if you have a catheter and you spend so much, you can still go inside and see how good it is. And imaging makes it perfect. Probably what I would have done is stepped up from the clopidogrel instead of acetrom to probably go for a better agent like a prasugrel or a ticagrelor.
I agree, but I think he's in a totally uncharted territory.
Definitely.
One stent, ruptured aneurysm, covered stent, and a plastic, which is not biocompatible that we are going to live inside, 2 stents. At that point for him, when somebody's had a complete heart block because of thrombosis and a cardiogenic shock, and he's got another 2 stents on the opposite side, if there's an hypotension, they may also thrombose because there's no endothelial coverage yet on that. If the risk of bleed is low, I think it's very prudent to, anticoagulate with a small dose, maintain an INR just around 2, not too much. Because we know for so many AF patients, we do this. We give aspirin, clopidogrel, and an INR of 2 to 2.5, and the bleeding risk is not tremendous. So I think it's relatively well established. If you think the risk of thrombosis is very catastrophic, you can use it for the shortest possible duration till you have the next strategy ready. I think this patient will always be safe if you can get and call him back, do another angiogram and get a bypass done. If there is another lesion, never do another angioplasty on the right side. That's my suggestion, because we don't have to be heroes. Patient is the center of what we do. We need to bail them out, but soon after we need to have a permanent solution, because these are young lives, one. And secondly, if you see another patient just like this, before stenting on the left side, please take your time, take the patient or call for an imaging, as Dr. Prabhakar said, OCT, IVAS, they will bring to your center if the patient can afford. Or please take him to a center where you feel comfortable and do imaging, do everything, learn it, so that, eventually.
One doubt, sir. Sir, in first instance, when I have seen that aneurysm on the right side, should I go for an imaging, and risk stratify the lesions, sir?
Absolutely. If I were to be, you ask me what would I do? I would probably do a bypass by ligating the RCA proximal to the aneurysm and distal to the aneurysm. In both places, you will ligate them. And anyway, he's got an LAD lesion, he qualifies for a bypass. The reason why I'm saying, that aneurysm is going to rupture sooner or later, because it was more than 2 times, almost more than the 2 times of the coronary. If the patient denies, I do not want a bypass surgery, can you fix it otherwise? Then I would definitely image and address the right coronary first, because it is an impending problem and more dangerous than the de novo problems on the left side. So I will wait for 1 day, call for an imaging, image that, and understand that, it is a thrombus layered or a pseudo aneurysm or a true aneurysm. If it's not it is not really more than 2.5 times this diameter, then I will wait on it and just address the left side. But if it did show, pseudo aneurysm, then definitely a surgery, not an angioplasty. Or if I want to do an angioplasty, I would get correct size, covered stents. Another small suggestion, the covered stent needs to be implanted at a very high pressures for a long duration of inflation. You need to keep it inflated for at least a couple of minutes to get the whole thing expanded and opposed to the wall. Oftentimes, in a rush, we take the covered stent down, inflate it at nominal pressure, and take an injection, still blood is leaking. So my suggestion, if you're doing next time, take a covered stent, deploy it at whatever the pressures. If it expands well, go in with an NC balloon and seal the proximal entry point. You don't have to go exactly in the center of it. If you just have only one covered stent, your duty is to seal the proximal entry point of that aneurysm. So you come up wherever the healthiest region is there, inflate the stent, covered stent, and then take a much higher balloon and dilate it. If it does not seal and you are left with nothing, take another metal stent inside, long one, 32, and go at much higher pressure so that there are no dissections.
Yes.
Thank you.
Thank you very much for the input.
Yeah. And also, you said there's not much to discuss about anticoagulation. I think you have great deal to discuss about anticoagulation. In this case, it's totally uncharted territory, and you are wise. But it's time to revisit by doing
a little bit of expansion on that, sir. What is the role of DOACs in this? I thought DOACs are going to be safer.
Yeah, I would also tend to agree, because in a non-mitral valve disease, we know that now NOACs are much better than oral vitamin K related anticoagulation. So I think you should get slightly bolder to use. But the challenge again is, what dose are you going to use? So it is, again, who's right, who's wrong, we do not know. If titrating the dose is a challenge and you want a good anticoagulation, maybe DOACs are much better. But if you're confident that he'll come back, you can manage his PT-INRs, then you can still use it, because we do not know. This is a total new indication.
Wonderful, wonderful discussion, sir. I think any other questions, anything on the chat box, anything that is there, anything from the audience on this case?
Yes, sir. Still, there is no question, sir, presently in chat box.
So in that case, I think maybe we should move on to Dr. Behra's case.
Yeah.
Beautiful, beautiful discussions. I learned a lot from Dr. Girish's discussions on this case. Wonderful discussions, sir. Great inputs. And I'm sure Teja will, given a chance next time, will definitely wait.
Go for an imaging.
Definitely image and proceed. And it's very, very important to consider that CAPG is a choice.
Yes, sir.
You have both the other vessels also diseased. That's another very important consideration to have. And never ignore an aneurysm, because it's an impending problem. And it happened in hospital. It had happened after he had gone back home. And he also gave a very beautiful explanation about why it happened in hospital, because of the anticoagulation that you give. I think that was fantastic. I never thought about it. Beautiful input, sir. I think with that we should say thank you so much to Dr. Girish for such an excellent discussion on this case. And next, I think we'll go to Dr. Behra's case. If you're ready, Dr. Behra.
Yes, sir. Good evening, sir.
Good evening, Dr. Behra.
Good evening, sir. May I start, sir?
Oh, stage is yours. Please go ahead.
Thank you, sir. Thank you. Firstly, I like to thank my mentor, Dr. P.K. Sahu and MQ Pharma. My topic is bifurcations are not always operator friendly. Going to some theory, what do you mean by bifurcation lesion? A lesion which occurs at or adjacent to a significant division of a major epicardial coronary artery. Now, classification, it can be classified as true and non-true. True bifurcating lesion, we say when the main branch and the side branch are both significantly narrowed, that is more than 50% stenosis. And non-true bifurcations are other lesions except the true bifurcating lesions. This is another classification in which bifurcating lesions have been classified. They have given 6 classification for bifurcating lesion. They are the Sanborn's classification, Duke classification, Safian classification, Lefebvre classification, Medina classification, and Movahed classification. Out of which the Medina classification is the most simplified and widely used. Here we use 2 digits, that is 1 and 0. 1 means there is more than 50% stenosis, and 0 means absence of stenosis. They are graded as from proximal main branch, distal main branch, and then the proximal side branch. It was given by Alfonso et al. In 2006. This is simply the classification. Now, limitation of Medina classification, the length of disease in the ostium of side branch does not account. The length of LMC before the bifurcation, trifurcation, it does not take into account. Vessel angulation, it do not take into account. No differentiation is made between a normal segment and a lesion with less than 50% lesion, and presence of calcification is also not identified. Coming to our case, coming to the history of the patient, he was a 54-year-old male who was diabetic for almost 10 years. He had history of classical angina of few hours duration. ECG was suggestive of acute infralateral STEMI. Echo showed hypokinesia in the inferior wall with mild LV systolic dysfunction with mild MR. Patient was planned for primary PCI. Now coming to the angiogram, he had a single vessel disease with 99% LCX occlusion. There was TIMI 1 flow and it was heavily thrombus loaded. This is the angiogram of the patient. This is LO caudal view showing thrombus present in proximal part of LCX, and this is the array caudal view showing thrombus in proximal part, and there is TIMI 1 flow. Our strategy was to wire the lesion, and then we would plan for a thrombosuction. Then we will be doing a pre-IVAS to look for plaque morphology, sizing of stent and landing zone, bed preparation of if required, stenting, post dilatation, post IVAS for optimization, apposition, and to rule out any complication. As per our
what is the status of the RCA? Is it a dominant normal vessel RCA?
codominant, sir, codominant vessel, sir.
Okay,
Sir.
very small.
Yes, sir.
Okay.
As per our plan, wiring of the LCX was done. This is the image video showing wiring of LCX. Then again we did wiring of OM1, which was followed by thrombosuction. Then we did a IVAS run of LCX. This is the bifurcation area showing fibrous plaque, significant fibrous plaque. Now coming to analysis of the IVAS, the A part represents the mid part of LCX showing minimal lesion. This is the bifurcating part with LCX and OM1 with present of plaque is there, and this is the part of LCX just before the bifurcation showing significant lesion. And E represents the proximal part. Here also lesion is there, and F represents the more proximal part of LCX which is disease free. The area we measured by IVAS was 2.868 and the lesion was 80% lesion. Then we did pre-dilatation of the lesion from mid part to the proximal part of LCX. Then angiogram shoots were taken after pre-dilatation, which shows TIMI 3 flow, and then we planned for a strategy. We will be going for a provisional stenting, but if side branch pinching is seen, we will be going for 2 stent strategy. And as per our plan, we placed a stent across OM1, sirolimus eluting stent 4 into 24 millimeter. Then angiogram shoot post stenting of LCX shows pinching of ostial OM1. Then again we did rewiring of OM1. Then post dilatation of LCX was done from mid part to the proximal part. Then we did kissing balloon dilatation of LCX and OM1. Then angiogram shoots after kissing balloon dilatation. Still there is OM1 shows 90%, around 90% pinching. Then we planned for stenting of OM1. Now stenting of OM1 was done with sirolimus eluting stent 2.75 into 16 millimeter, followed by kissing balloon dilatation. Post stent, this is the angiogram shoot. So after stenting of OM1, which shows complete TIMI 3 flow, but in the stent of LCX, distal to LCX, there is some haziness. This one. Then we again did a IVAS run of LCX, which shows a dissection in the part after the stent. This is the dissection part. Then analysis of this is the A represents the part after the stent, which shows no dissection. This is just after the stent, and the C image shows the dissection. There is D represents the part of the stent showing apposition, good apposition. This is the E represents the part with showing the bifurcating part with good apposition, and F is the proximal part of stent with good apposition. The type of dissection in our case was a type A dissection. Then we planned for stenting the mid LCX part, and we did it with a sirolimus eluting stent of 3 into 18 millimeter. Then angiogram suits were taken after stenting, which shows TIMI3 flow. Then again we did a IVAS run of LCX. No. Analysis shows this is the distal part of stent. Complete apposition is there. B represents the stent showing complete apposition. This is the bifurcation part with apposition, and no struts are also present. D, proximal part of stent. Then we also did a IVAS run of OM stent, which also showed good apposition. And this is the distal part of stent, and the C image represents the bifurcating area, showing good apposition, no struts, overhanging struts. And D is the LCX stent showing good apposition. Final suits, pre-results. The left video shows pre-results and the right video shows post-results. All well. Learning points from our case. Provisional stenting sometimes need alteration to two-stent strategy. Respect to side branch during bifurcation, stenting is important. Liberal use of imaging studies during coronary intervention should be encouraged. Thank you.
Thank you, Dr. Behra, and I really appreciate your understanding of coronary imaging. So it is nice to know, and your mentor, Dr. Sahu, is he's been in this for long, and he's a wise man.
Yes, sir.
What I would like to tell, and I welcome Dr. Sirish Hiremath, sir. Nice to see you. I think we have woken you up. Right. My only suggestion, when you have done so much,
sir,
be liberal in the length of the stent whenever you are dealing in an acute coronary syndrome, because your understanding of the healthy region is not accurate. Where is the proximal healthy region? Where is the distal healthy region? And second, always be prepared to have a provisional stenting and place for POT, proximal optimization technique. So what I personally felt, although you had a good strategy, there were challenges. If you could mute others, it'll be great. What I realized that, your stent was short and landed in the disease segment. You had the luxury of imaging, so that could have easily predicted what length of the stent you could have used. And also, if there's a need for a second, bifurcation stent required, the length of the pot and what is the diameter. When I saw the second OM imaging post-stenting, there is still under expansion. If you will see a black halo around the stents. These are my two observations. You could have had a little longer stent and probably a good pot area to give you, that could have helped you to prevent implanting the third stent. Otherwise, fantastic understanding.
But I like the idea of putting in a 4 millimeter stent. I think that was very courageous. The circumflex is very difficult to judge. And most of the time, people end up putting a small diameter stent in circumflex, believing that they have done a good job. So putting 4 was a very courageous decision. It cost you in terms of distal dissection.
Yes, sir.
But I think putting 4 was a very good idea. And rest of the steps could be, as Dr. Girish suggested, pot, and then side branch wiring, and then whatever next. But excellent result. I think result finally is brilliant.
Where was your IVAS manual pullback or an automatic pullback?
Automatic pullback, sir.
Because in an manual pullback, you can't measure the length.
Sir.
Because an automatic pullback, definitely you can measure the length and go to a very good normal to normal segment. And probably there must have been some disease, otherwise it doesn't dissect. And sometimes your imaging, you have to be a little careful. Probably slightly undersize these stents, because in OCT you get a good EL to EL, and then you look at the luminal size. Luminal you can go up, EL to EL you scale it down. In IVS, these guys are sometimes when they measure it, they goof up a little bit. So probably slightly undersized. You can expand these stents, because most of the stents can be expanded by 0.5 millimeter. And you had the imaging there with you.
Sir.
So you can always look at the opposition and how the stent is expanded, and you can always look at it as you go. But
Dr. Prabhakar, what are you suggesting? He should have taken a 3.5 diameter stent and back end with 4.
So I don't know what he saw there in the distal vessel size. Probably it was a little oversized. That's probably the reason why it was dissected. That's what I thought.
So what are you trying to suggest?
So take a 3.5, do a pot. Take a 3.5. Pot would have been 4. So what would have been the distal vessel? Probably would have been the correct one. That's what I thought.
So what Dr. Prabhakar is trying to suggest is the stent diameter should have been 3.5, and the back end should have been done with 4.0. When you talk of things like this, you must make sure that you have about 8 or 6 millimeters proximal length of the stent, proximal to the bifurcation. Because I think the smallest length of pot balloon that we have is either 8 or 6 rather, let's put it that way. So I would have 8 or 6 length in the main vessel proximal to the bifurcation, so that you can go on a good stretch with 3.5 diameter.
One suggestion, when we start implanting stents, what is important to understand is size the stent for the distal vessel.
Do you know?
When you use a metal stent, your diameter of the stent should be for the distal landing segment, and then post dilate the proximal. Today's stents, you can upsize it by minimum 0.5 and up to even 1 millimeter. So that is for metal stents. If you're using a biovascular scaffold, now we have that mirrors, then you have to use the proximal. You have to size the bioresorbable scaffold for the proximal size, not for the distal size. And it will accommodate in very less chance of dissections. So I hope I make this point for you clear. Even if you see 4 mm, you match it to the distal and then post dilate the rest.
Sir.
Dr. Girish, that stretch the scaffold even with a bigger balloon and a higher pressure is very tough. It will not get stretched to the way the metal stents can be stretched.
Absolutely.
If we are taking a bioabsorbable stent, I would probably match it 1-to-1 with the diameter and deploy at low pressure, and then stretch the back end with high pressure.
Absolutely, sir. I think we need to take 1:1 for the proximal size, the largest diameter, and then use appropriate post dilatation. Otherwise, you'll not. If you take a 0.5 millimeter smaller scaffold, you would not be able to get a very good apposition proximally. Even if you take 0.5 millimeter higher and then implant lower, these are very, very, semi-compliant to non-compliant balloons. They don't blow it up so much to cause a dissection distally. So you need to size it for proximal if it's a biovascular scaffold. If you're taking a metal, size it to the distal segment.
Also, under this kind of setting, where you're dealing with acute infarct situation, you would expect thrombus, no question, and the stretch that we give with a balloon may have its own limitation because of distal embolization. So use very high pressure, could be more distal embolization. So I would probably feel that taking a bigger diameter and low pressure is a good idea. And of course, finally, you use high pressures.
Very true. I mean, remember
you
this
didn't
one.
think of putting in a distal protection device or anything?
No, sir. No, sir. We did not use any digital protection device.
But I thought this case could be an indication that also.
But I think I should appreciate your boldness to take I was 3 times or 4 times in an ACS, because that itself can embolize. I've seen many operators, as Hiremat sir said, you just take slightly larger stent, go at a subnominal pressure, deploy it, don't try to do aggressive post dilatation, get a good TIMI3 flow, because higher the post dilatation, more is the tissue prolapse into the struts and more is the embolization. Also, the clot, when it gets squeezed with a higher pressure post dilatation, infuses inflammatory mediators into the distal microvasculature and cause significant slow flow or no reflow, even if there is no thrombus. So these are all small things to remember in acute coronary syndrome.
Coronary bolus GP blockers was not used, but it was used.
We used only 2.5 ml, sir.
What
Not-
was that?
Bolus.
Bolus dose only we used. Tyrophiban we used.
But that's not a correct calculation, 2.5 ml.
But this is done in several labs where what they do is they think that the antiplatelet effect is not there because it takes time for the ticagrelor or the prasugrel to act. Before that time, when you do the plasty, for the initial antiplatelet effect I give, I've seen it in several labs.
No. I'm not talking of giving. In fact, I'm all for giving. I'm talking of the dose. 2.5 ml is not a dose for tirofiban intracoronary. I think if you calculate, it will probably be between 10 ml and 8 ml.
Absolutely, at least 8 ml.
Yes.
You use medically guided therapies. Don't be afraid. No half-hearted approaches. You're appropriate in using it in ACS, at least the bolus dose, especially when you have the anxiety of distal slow flow. Use a GP2B3A, give a nitroglycerin, or even if it required a little bit of, adenosine or something, if you want to prevent a no flow or a slow flow, because very difficult to treat, easy to prevent.
Okay. I routinely use nicorandil. The moment there is an antigrade flow, I routinely give one nicorandil, 2 milligram, intracoronary. It helps in all these no flow, slow flow phenomena. And what Dr. Sirish said about a slightly bigger size stent and don't go for higher pressure. I learned it the hard way during the initial days when we started doing primaries. We used to use the correct size and go for a higher pressure to get something. And then I realized that this is the time when you start getting all these no flows and slow flows. So I developed 2 strategies. One is routinely give nicorandil, whatever happens, just don't bother, just give a 2 milligram nicorandil, it's safe. And second thing is use a slightly bigger stent, but don't go for higher pressures, but get a good stent inside. And it works most of the time.
Also, for acute MI, go slow on the entire procedure. There's no fun in finishing the procedure in 10 minutes and 15 minutes and coming out. I think let the artery breathe. So once you open, give dilators, give GP blockers, all this takes time. Let the effect come fully before you take a stent and do the final finishing touches. But I would feel the stent strategy was extremely good and final results.
Do you routinely go for this inflation and slow deflation, one bar by one bar, so that sometimes if you deflate fast, they say that the thrombus is attracted. It sucks the thrombus from the vessel wall. You believe in that, sir?
No. I mean, I would generally be inflation also would be slow. I mean, initially from 0 to 4, I will go quickly, because if you are very slow at that time, the stent can move forward or backward.
No, deflation, sir. Inflation fast, no problem.
Yes, so inflation up to 4, I go quickly, And then 4 onwards, 4 to 8, I would probably go half. Every half, I will give a little pause. And deflation also very slow. Yes. I think this is the difference you must make between chronic stable angina and AMI case. All right. So any other questions in the chat box or on this case?
Ravi, are
Dr.
there any
Walker,
questions?
in this case, since both the vessels were very big, would you consider a 2-stent strategy to begin with?
Hello, sir.
I mean, both the vessels, the OM as well as the basic circumflex, they were good sized vessels. So would you consider a 2-stent strategy to begin with?
No, sir. We actually thought of going for a provisional stenting only to the culprit artery, that is LCX. But since on table there was pinching of OM1, we thought of next we thought of going for stenting of OM1. But initially we thought
that
of.
I understand. Given here we are talking 4 and 3.5 diameter. So I would probably feel that stent strategy also could have been a very effective strategy.
Okay.
Dr. Prabhakar, in these kind of acute situations, would you like to use culottes technique?
If I had given a choice of this particular case, I would have, because the imaging was done, there was a little doubt about the OM lesion, and they imaged the circumflex, and I would have gone for this, but definitely I would have prepared for a pot, like you said, 10 mm or 8 mm to 10 mm proximally, and then go ahead with it. Culotte, I would not have really gone ahead with culotte. Somehow I feel that culotte takes a lot of metal inside. Maybe it's faster, but since it takes a lot of clot, I would have gone more, like you said, with the definite provision for a second stent.
Yeah, I think the harder lesions are the one which are better addressed with culottes.
Culotte.
This was a soft, mostly thrombotic lesion, and be easily done the way the doctor has done. What about Dr. Girish? Any thoughts for this case?
I think I would do what they have done, sir. Provisional would be much easier because in ACS, I would like to be as less metal as possible and get out as quickly as possible. Just that I would have used much longer stent in the circumflex. That would have made my life easier. But if I had a 2-stent strategy, I would deploy both the stents simultaneously. I wouldn't either do a DK crush or a culotte. I would take both of them, dilate them, first do the OM, not simultaneously, I'm sorry. First end the OM, ostium, and then get the balloon back and then inflate the circumflex, then recross and do the pot. And in ACS, the time is everything. The quicker you get out, less complications and better outcomes.
No, I think that is all better understood, but I feel quicker means establishing a forward flow. Okay, it doesn't mean end of the stent. So the moment you get a forward flow, your heart is breathing. So I think the damage is getting truncated, yes, shrunken. The moment you establish a flow, it doesn't mean finish end of the procedure. So once you get a forward flow going, I think you have time on your side.
Couple of questions on his techniques, Dr. Sirish, your comments on that. He has done a stenting to the circumflex straight. Then he has done a balloon. He has done a kissing to the OM first. Like it's like a reverse DK crush that's going on. And what do you think about that, sir?
Well, going to start to the side branch, that is the OM in this case. When you want to do that, you have to have a balloon in the main branch stent. So it would be unnecessary to do a kiss at that stage. I would also do
kiss
but
there directly.
Don't get the side branch balloon deep inside. Side branch balloon should be just looking maybe 1 or 2 millimeters in the side branch. Majority of should be in the main branch.
So just open up and then look at it. And no, the point is like do a tap, get inside, once you've done a dilatation of the strut and found out that the plain balloon doesn't work, you're going to do a tap, get a stent inside, and then crush it and go ahead, because anyway you are there in the lumen. And I thought that would have been faster and simpler.
No. Once you decide to put in a stent, all the steps that were done were absolutely correct. You're probably repeating the same thing. That I'm talking of cases where you probably just want to do a balloon to the side branch and probably wait and see if you need a stent. At that stage, I won't get the balloon too deep into the side branch first. I would probably stay close to the stent.
And you will size the balloon 1:1, or it's less than 1?
No, 1:1.
1:1 only.
And low pressures, 4, 5, 6 at the most. 4 is my usual.
If there is not much disease in the ostium of the OM, 1:1, just 2 millimeter prolapsing across the stent struts and going at even 6-8 pressures would be good enough to open the struts. But if the osteoproximal part of the OM is diseased, then probably you would take a slightly longer balloon, maybe 12 or so, go into the distal healthy aspect of the OM, maybe 4 or 8 millimeter into the OM across the stent, go at 4 atmosphere and stay open for about 90 seconds. Then come back and then do another dilatation across the main vessel if you're satisfied with the side branch flow.
If some disease in the side branch, maybe 50%, or maybe something which you would not normally stent, but if you're stenting the main branch, and the ostium of the side branch shows 50%, I would be very inclined to put another stent. There is no sort of necessity to shy away, because see, then if you do a balloon dilatation, patient comes back with a reaction to the dilatation, it will eat up the entire area of the side branch as well as the stent, and then you would end up with an IS bifurcation, which is very difficult to address.
There is
putting second stent in the side branch, though the region is only about 50%. I'm thinking.
I agree. If the side branch is more than 2.5 millimeters, close to 2.75, whatever you have, it's safer to put in a stent.
Yes.
Now, sir, your opinion that a lot of people are talking about DEB to the side branch. If it is 2.5 or lesser.
So I want to have a good side branch. I would put in a stent. I mean, to me, things to stents is not an issue.
Sure.
Only thing you have to do a perfect job.
That's important. I think in good hands, 2 stents fare very well. But you must understand, trying to do a good distal crossing, then recrossing, kissing, final kissing, pot, all that takes the time. You need to be a real good person in terms of your skills.
This way that this patient to one stent, the DEB, and patient comes with an ISR. It's a hell of a job, ISR in a bifurcation with one stent already placed. I think it's very poor long-term.
I agree, sir. But also the stents which are less than 2.5 also have a significant higher ISR in a bifurcation situation. So that's why they think less the metal may be better future options. If he has a 2 stent and has a ISR.
Clearly, Dr. Girish, we are arguing whether balloon will give more ISR or stent will give more ISR.
Right.
Clearly, we are talking of 30% versus 2%.
No, drug-eluting balloons, sir, I was just asking.
So even then, not a great idea.
Good.
If you have a mid-vessel lesion, I think drug balloon. Okay, time to move to the next case.
I think we have 2 cases only today.
Sir, Hemant sir, you want to present your case, sir?
Yeah, I also can present.
Yes, sir. So we have completed, sir. Both the speakers have completed their presentation.
Oh, is it? I was so late. Okay, Manish, can we go to the case presentation?
So I'll just tell Manish to connect to 1 minute.
Dr. M. Fani Teja sir has presented first case, sir. It was really nice and very insightful case. So
I was so late. I'm struggling with the American time in India.
Dr. Fani, you want to share anything about your case till the time the other sir case can share the case?
Possibly you can show those couple of slides how you made your indigenous covered stent.
Yes, sir. I will try to. Yes, this is the first initial presentation, sir. The patient who had undergone PTCA to RCA presented with coronary aneurysm. Then when we have addressed the left system, patient has developed stent thrombosis. Patient has developed has gone into CHP pericardial effusion, and here we can see the leaking aneurysm, sir. We have only one small covered stent available, 2.8 into small covered stent, 16 mm covered stent, which was not able to seal the leaking aneurysm. This issue is after deploying the covered stent, which was still leaking. So we have prepared an indigenous covered stent, sir, using 2 drug-eluting stents.
Get our screen.
We have cut these are the steps, sir. The first stent is partially inflated outside the patient's body, sir. We have cut the ends of the balloon circumferentially. We have taken out the balloon as well as we have taken out the stent as along with the balloon sleeve outside, and we have put this whole assembly, that is the stent and as well as the balloon, onto the next stent and crumpled it, sir. Then we have placed the whole assembly, which included the stent, sleeve, and stent into the desired site. This also. This was balloon sleeve, which we have taken from the first stent. We have put on the second stent. And this was the stent of the first stent.
I think gloves are too loose for him.
We have crumpled it. Balloon sleeve stent onto the second stent, sir. This was the final shoot, sir, which has completely solved our issue of leaking aneurysm with distal Dimitri flow, sir.
So balloon sleeve should match the diameter of the vessel. Not necessary.
Sir?
The balloon sleeves that you do should be same diameter as the vessel.
Yes, sir. We have taken 2 similar size stents, sir.
Okay. All right. Should we go over to my case?
Yes, sir. Yes, sir.
Manish, leave it. I will take care. So this is a gentleman who was actually going to retire from the police job. Pre-retirement, he wanted to take an insurance and things like that. That's why he underwent a stress test. 10 years back, there was some question. He had chest pain and it was a question mark cardiac pain. But ECG just showed non-specific changes at that time. Echo was normal. And this is the right coronary artery, which shows some disease in the proximal portion and the total occlusion. So reasonable to assume this is probably 10-year-old CT. You can see calcium fluoroscopy, and I will show you retrograde filling from the patients. This is the CTO RCA, question mark, 10-year-old, test is positive. Patient had no symptoms, but he was very keen on getting it fixed because he says, once I retire, I'll get reimbursed. So we came with Gaia 2. I think this was our initial experience with Gaia, and somehow did not cross your lesion, but I think if I were to use Gaia now, the way we have made some changes. Never touch the tip of Gaia. Let the shape be just what it is and work on it. And we keep working with the support from behind, and you would find Gaia should cross in. This was our initial experience, and this Conquest 12, I think this crossed support from behind. Just escape. Conquest Pro 12 cross can see this towards PLV, and all these advances of the wire were monitored with simultaneous contrast injections. But every reason to believe that the wire is the correct lumen and going in a good direction. PLV was a much bigger branch compared to PD. I would probably take more support. Then we ran into another problem, though the wire is in good position, you can see left injection. The balloon was not growing, and when balloon doesn't cross, we have to sort of think of doing something different. So many would move down from 1.5 to 1.0, then maybe 0.85. These kind of downsizing we did, but yet it did not work. The balloon could be supported from behind with a deep guide catheter position. And probably what we could have done is placed another wire and balloon in the side branch proximally so that anchors the guide catheter. And then you can go further deep into the vessel. We tried some of these techniques, but did not work. And this is what are the ways in which we can think of doing if the balloon is deep. One is take a long sheath in addition to a guide catheter. So we always work with 50 centimeter long sheath. Take guide catheter, give support. Downsizing we did not work. Then we used a Nick Nano Hydro. This is 0.85, very sleek balloon. It crossed very easily. Then sometimes we try to advance my method, but these are clearly fatter than the smaller diameter balloons. So I would do that. And then we can use Corsair or Taunus. As I told you, we can use anchor balloon in the branches going in the proximal sides. And these days, of course, GuideZilla and GuideLiner are very good supports. So the balloon would go through a GuideZilla. GuideZilla would come to the site of fusion, and that we will advance the balloon to give the root support behind. And of course, bigger diameter guide catheter also would give very good support. And if nothing works, we need to go. These are some other cases where we have taken help. In this case, we have flapped. You can see flap proximal CA. Distal vessel is quite good. And here we have used Nick Nano Hydro 0.85. This was not going. So we would probably leave the wire there and put another wire on the other side and try to take it. Because this wire could have gone subintimal and then come back in. We should not push it. I would probably think put another wire and then take support from behind, like in this case, the GuideLiner is there, and with that balloon crossed, and this is final result. Then sometimes whenever balloon cannot cross, like here 1.25 balloon not cross the site of flow occlusion. This is on the case. The Corsair with some kind of rotatory movement. You can see the progress of the Corsair. See, here you start giving rotation and it will move millimeter to millimeter, get into the distal vessel, and Corsair does that in this case. Corsair is clearly different from a microcatheter. It has a taper, and microcatheter is to take you up to the lesion. I think if you have to cross, I think Corsair is necessary. And because of it has a tapered tip, which is quite stiff, the passage across the total occlusion is quite good. Now you can see here the collateral specifying the distality of the right coronary artery. The lesion length of the CTO is quite long. And here we are using conquest flow with a balloon support to the guide catheter. So what we have done is proximal, this one, and you can see we have placed a wire and a balloon there. So this fixes the guide catheter. And when you're trying to advance through the CTO, the guide catheter will not get pushed back. This is an anchoring technique which helps. And you can see the area of projection. Similarly, the anchor balloon in one of the proximal portion, and the wire is advanced under contralateral injections. You can see left injection. We are following the progress of our main branch wire. So here is a support behind, and wire is advanced, and this is obviously a CTO wire. You can make out to long opacity. This is the primary. So there will be many ways in which you would address the total occlusion. This is our basic case where we have Conquest Pro 12 in position. This is another case where we have changed. First, we did do a rota. In rota wire, before it is withdrawn, we get a microcatheter. This is the tip of microcatheter through which you advance a strong support wire on which you take your balloon. So in our case, since the balloon was not going, nothing was going. So we decided to get a rota. Getting a rota wire where earlier Conquest 12 has gone is again a little bit of a challenge. So you get the microcatheter all the way down on that wire which is crossed. Try and push the microcatheter as much as you can, because rota wire is 09 and it's not going to be a strong wire to make advance through the video. So the micro has almost at the distal end when we advanced the rota wire, and then we did a word with 1.25. We are still not happy with the distality where we have placed the rota wire. It has probably gone into PD and not the PLV, which was the original. So this is another different case where we feel there was a stent oscillation, but patient had symptoms, and then this was the lesion to be done or not to be done. This was the issue. In ariocaudal, it looks important. In epicranial, it didn't look important. However, we do FFR and FFR 0.7. Then we decide to do this, which showed ground calcification, and then we decide to stent it. This is the final result with the stent. So what you see on angiogram may not make final decision. Like in this case, we have taken help of an FFR and we have also done cut the calcium. You can see around 360 calcification. If we had not done that, we would probably not get this kind of very satisfactory result. In some other case, this was a case which had failed referral center because they tried to do this and waste, get out waste. Our lab, so we have a strong belief in sprinter. Waste persisted. Here is a case where we used an OPNMC and the waste went away. So this balloon can go very high on pressure. So go up to 10, 12, 15 quickly so that it is fixed, does not move the position, and then gradually inflate to maybe 30. Then you can have this shockwave balloon. Every shock it hits the calcium and has what the tablator. In this case, we took a balloon distal. We wanted to be safe once we have the balloon distal. We got this anchor catheter. So the anchor catheter is now going to remain in the vessel, and we are going to deploy the same attachment. So OPNNC is used at very high pressure, 3 mm diameter. The good part about OPNNC is that it doesn't swell. I haven't had a single perforation despite going to pressures like 40, 45, and even 50 at times. So after doing anchor balloon dilatation, the guidezilla is advanced. It is almost coming to the bifurcation, time to take the stent. And this is the first stent which has come out through the tip of the guidezilla. Under these kind of occlusions, guidezilla is very, very supportive. The stent is in position. Then we post-dilate with OPNNC. OPNNC, very good because it doesn't swell and it's unlikely to hurt the diameter of this. And this is the second stent. So two stents are touching each other. This is again stretched with OPNNC. We had to take the guidezilla inside with a strong support from the guide catheter also. And this is how we find result. It was like a 10-year CTO. You can see a nice dominant vessel with a good distal ramification. So I would feel, on my wonder, why did we do it? I mean, if the function is 10-year-old and patient has lived 10 years, should we do it or no? I think this kind of question with normal function, these kind of questions come to our mind. But for somebody who is just 58, I would feel revascularizing. I will stop here. We started and this is how we ended. Two stents.
We tip. It's a fabulous case, sir, and we tip your hat. We tip our hats to you, and everything that is there to try in a CTO, especially in the mid to distal RCA where there is an acute bend that would happen. The greatest learning here was when the wire tracks, when other things don't track, how to analyze the problem and what are the options to look for. I think, as you greatly said, guide support is the most important thing. Second most important thing is some kind of an anchoring that would really help to push the subsequent tools such as microcatheters or a balloon catheter across the CTO segments. And
also long sheath.
yeah, absolutely. Long sheath in the groin, in the up to the abdomen. It's all more to do with the anticipation. The minute you do an angiogram and do a contralateral and antegrade injections, you have a strategy. I think we need to have everything planned out. What guiding? I mean, what sheath in the groin? What is the guide? What are the wires? What is the anchoring balloon technique?
The guide also is important, Girish. I mean, normally we all do work with 6 French, but for difficult cases like this,
I think it's always 7 French. I think so. Anything more than simple, I think we're always safer to use 7 French guide. It's very versatile, gives you so many tools to be used simultaneously. That's a great learning. And
whatever Dr. Girish you mentioned, they're all summarized here. We have a long sheet, 55 centimeters. Guide is a fatter guide, 7 French. Then actually I forgot to mention, we changed to AR, which is probably better support than conventional GR. And then we used a guide catheter extension. So these are all 3 important steps. Long sheet supports your bigger diameter, that to an AR will help you into the vessel, and catheter will take you absolutely. The choice of wire generally start with simpler wire and things like that. But I think when you feel the CTO is true CTO or long duration CTO, I think it's probably waste of time trying to take a simple, etc. I would probably feel these cases, I would take Gaia 2 or 12, 20, way we have done this case. Rota is a very good train when balloons are crossing. Once Rota is done, consider high pressure PNNC balloon as this case. There are some cases where we have used to cut the mineral calcium and also used a shock wave to hit the CT. Rota would probably not help hit deep CT calcium, which is addressed with this IVL deeper calcium. That is how you can get an issue. Thank you indeed.
One small question, sir. When you use the OPN balloon, once you go to higher pressure and deflate it, it never collapses fully. And especially when you are delivering it in a guideliner or a guidezilla, what happens is it doesn't really come out through that. I've had problems with that. Any tips for that?
Yes, I think this is very important. You use high pressure on a coated wire, especially on a coated wire. The coated wire sticks to the balloon. You are trying to withdraw the balloon, the wire comes out. So I have many times using high pressure, I have a wire on the side. If you sucks out wire on which you sent it, the wire is there on the side. The other thing is hydrophilic wire and high pressure OPN is not a good combination because the coating, surface coating, which is used to make the wire
Sticks.
It sort of melt. It will stick to the balloon. So whenever I'm taking high pressure, and I'm using it on the wire has taken a lot of time.
Thank you, sir. I think we had excellent case. I think we learned a lot from the master's case in the end, and I think all the tips and tricks for a difficult RCA. RCAs are always very difficult, and the recent problem I faced was with the OPN balloon. That's why I asked you, what is your trick? I think probably the key is to use the second wire always. Keep a second wire backup, even if this, just pull out the whole thing and proceed with the second wire.
Especially if you're using a OPN NC balloon on
Hydrophilic wire. I think we should thank you for excellent tips and an amazing case, and you pulled in all your other techniques also for this particular case. I think we learned a lot into this. Dr. Girish, any final words, sir? I think we are 9:40 on time.
I know. Sorry, I think there's hardly anything after the master has spoken. But one last thing we had seen was granuloplasty. When nothing goes in, you could use a very small 0.85 or 1.0 balloon, and then go at 18-20 pressures and burst that balloon. It causes some alteration in the proximal cap, which is the hardest of the entry points in the CTO segment. So occasionally that could also be a tool. I mean, I could just think only of that after all the methods Hiramat have spoken.
I mean, here the balloon has gone through the entire length of the CTO, or just wherever it sticks. It cannot. It cannot go advance further.
There you blast the balloon, sir. It creates that pressure creates fractures as well as the false tracks, subintimal tears.
Have you crossed the entire length of the CTO, or wherever?
No.
Wherever balloon
wherever,
is stuck, maximum.
Yes, sir. Wherever the balloon is stuck or a microcatheter is not progressing any further, at that point we need to take a balloon and then blast that balloon, sir.
All right. Thank you.
Thank you. Wonderful.
So thank you. Yes, sir. So once again, from behalf of MQ, sir, thank you so much. And even in absence of first case, Dr. Sirishwar sir was not well. Still, Dr. Girish sir and Dr. Pravakar sir was managed very well. And thank you, sir. Thank you so much, Dr. Girish sir and Dr. Pravakar sir. And thank you, Shirish sir. And also thanks to our both the speakers today, Dr. Somen Bera and even Dr. Paneet Teja sir. Thank you so much for the excellent case and a lot of insights from all of your case. So once again, thank you so much. And any final point from Shirish from your end?
No, we always remain thankful to MQ. I mean, though pharma takes so much effort and pains to get the interventional cardiologists together and driving a show which is purely a cath lab show. Thank you indeed for that.
Thank you, sir. Thank you so much, sir. Good night. Good night.
Thank you.
Good night.
Good night.
Good night. Good night, sir.
Should I end the meeting for all, sir?
Recording stopped.